This is my Preparator series for NEET PG. Concise, exam oriented notes for the first revision. Let's start. Today we are revising vitamin A integrated across various subjects with an exam oriented approach. The first subject is physiology. In physiology, we have Wall's visual cycle. In our retina, we have a photoreceptor layer which contains two types of cells. One is rods and the other one is cones. In the rods, we have a pigment called as rhodopsin. When light strikes rhodopsin, it gets converted into luminorhodopsin. Luminorhodopsin then gets spontaneously converted into metarhodopsin 1. Metarhodopsin 1 again gets spontaneously converted into metarhodopsin 2. This metarhodopsin 2 gets broken down into two compounds. First one is opsin and the second one is all trans retinol. So the all trans retinol ultimately needs to get converted into 11 cis retinol so that it can combine with opsin to form rhodopsin to complete this cycle. This happens in two locations in our human body. The first location is the eyes and the second location is in the liver. In the eyes, the enzyme retinol isomerase acts on all trans-retinal and converts it into 11-cis-retinal. In the liver, alcohol dehydrogenase acts on all trans-retinal and converts it into all trans-retinol. The enzyme retinol isomerase acts on all trans-retinol and converts it into 11-cis-retinol. Alcohol dehydrogenase acts on 11-cis-retinol and converts it into 11-cis-retinol. In the end, we have 11-cis-retinol. 11-cis-retinol combines with opsin to form rhodopsin to complete the Wall's visual cycle. Now, we might wonder from where the nerve impulse is generated for vision. Now, for that, we have to focus on the compound metarhodopsin 2. Metarhodopsin 2 activates a substance called as transducin. This transducin activates an enzyme called as phosphodiesterase. This phosphodiesterase converts cyclic GMP into 5-GMP. Let's take a look at what is happening inside the rod cell. In the cell walls of rod cell, we have several ion channels. The first one is gated sodium channels, which allows for the influx of sodium ions inside the rod cell. Next is sodium potassium ATPase pump, which allows for efflux of 3 sodium ions and influx of 2 potassium ions. We have ungated potassium channels, which allows for the efflux of potassium ions. Next, we have gated calcium channels, which allows for the influx of calcium ions inside the rod cell. When phosphodiesterase converts cyclic GMP into 5-GMP, the concentration of cyclic GMP decreases. This decreased cyclic GMP concentration closes the gated sodium channels. This leads to decrease in the influx of sodium ions, and this decrease in the positive ions inside the rod cell increases the electronegativity inside the rod cell. This leads to a situation called as hyperpolarization. This hyperpolarization further closes the gated calcium channels. This leads to a decrease in the influx of calcium ions inside the rod cell. This further increases the electronegativity inside the rod cell. This increase in electronegativity decreases the secretion of glutamate from the rod cell. Glutamate is an inhibitory neurotransmitter. This decreased synthesis of glutamate or inhibitory neurotransmitter stimulates the bipolar cells, which allows for further transduction. Now, the second subject we are going to discuss is biochemistry. In biochemistry, the second concept that we are going to discuss now is toxicity of vitamin A. Toxicity of vitamin A is known as hypervitaminosis A. When a human being intakes vitamin A, it gets digested and it gets transported into the liver via the chylomicrons because vitamin A is a fat soluble vitamin. In the liver, it gets stored in the lysosomes. Now, take the condition of a Arctic explorer. An Arctic explorer during his explorations may face scarcity of food and may be forced to kill a polar bear and have it for his meal. When an Arctic explorer consumes the liver of a polar bear, he will be facing a condition known as hypervitaminosis A because even in polar bear, liver is the storage organ for vitamin A. Hypervitaminosis A can manifest acutely or chronically. In acute manifestations of hypervitaminosis A, we have pseudotumor cerebri, exfoliative dermatitis, hepatomegaly, hyperlipidemia, teratogenicity, and keratoderma. Pseudotumor cerebri is a condition where, even with the absence of tumor inside the cerebrum, we face symptoms which are related to increased intracranial pressure. Keratoderma is orangish discoloration of skin and mucous membrane. In hypervitaminosis A, keratoderma manifests in three locations: face, palms, and soles. Here you can see the face, palms, and soles have become orange in color. The chronic manifestations of hypervitaminosis A are bony exhaustosis, which can lead to bone fractures, and liver cirrhosis. The third concept is normal levels of vitamin A, that is the recommended daily allowance for vitamin A. In children between 1 to 6 years of age, RDA is 400 micrograms per day, whereas in adults it is 600 micrograms per day. In pregnancy, it's 800 micrograms per day, and in lactation, it is 950 micrograms per day. The fourth concept is deficiency of vitamin A. Deficiency of vitamin A manifests in two important organs. First one is the skin, and the second one is the eyes. So, vitamin A deficiency in skin is known by a term called as phrinoderma or follicular hyperkeratosis. It is because of a multifactorial deficiency, out of which vitamin A is the major factor deficiency leading to phrinoderma. Other factors which can become deficient leading to follicular hyperkeratosis is vitamin B complex, vitamin C, vitamin E, riboflavin, and essential fatty acids. Location of phrinoderma is in elbow and knees. Here you can see follicular hyperkeratosis in the elbow and the knees. Next is in the eyes. The vitamin A deficiency manifestations of eyes are graded by World Health Organization. The first stage is XN. The features of this stage is night blindness. One liner which is important here is it is the first symptom of vitamin A deficiency in eyes. The pathophysiology happening here is it is due to the lack of rhodopsin. Next stage is X1A. Here, conjunctival xerosis is seen. One liner which is important in this stage is it is the first sign of vitamin A deficiency. It is due to conjunctival epithelial alteration and loss of goblet cells. Next stage is X1B. Here we can see Bitot spots. One liner which is important here is it is the pathognomic feature of vitamin A deficiency. Here it happens due to conjunctival keratinization and plaque formation. Next stage is X2. Corneal xerosis is seen here. It is due to corneal epithelial alteration. Next stage is X3A. Here, keratomalacia or corneal ulceration affects less than 1/3 of the corneal surface. It is due to the liquefaction of corneal stroma. Next stage is X3B. Here, keratomalacia affects more than 1/3 of the corneal surface. Pathophysiology is the same as above. Next stage is XS. Here, corneal scarring happens and it also occurs due to the same pathophysiology mentioned before. Last stage is XF, xerophthalmic fundus. Here, whitish beaded appearances are seen in the retina. It is due to the degeneration of retinal pigment epithelium. Another important one-liner is vitamin A deficiency is the most common cause of preventable childhood blindness. So, out of these stages, from the stages XN to X2, the four stages are actually reversible. How can we reverse these four stages? It is by means of treatment of vitamin A deficiency. With this, we are moving to the next subject, ophthalmology. For treating vitamin A deficiency, we have three age groups. First age group is less than 6 months. When the baby is less than 6 months of age, we give 50,000 international units orally, whereas when the baby is between 6 to 12 months of age, we give 1 lakh international units orally, and when the baby is more than 1 years old, we give 2 lakh international units orally. Timing is on day 1, day 2, and day 14. Next concept is prevention of vitamin A deficiency. Here also we have target groups based on age. When the baby is less than 6 months of age, the dosage is 50,000 international units orally, but here it is given only when it is required, that is only to the risk population babies. But when the baby becomes 6 to 11 months of age, the dosage is 1 lakh international units orally, but the dosing here is compulsory and the frequency is only once. And this is given during the ninth month along with measles vaccine. The third age group is 1 to 5 years of age. Here the dosage is 2 lakh international units orally. Here the frequency is 8 times, out of which the first dose is given at 15 to 18 months of age along with DPT booster. The remaining 7 times follow the first time by a gap of 6 months until the age of 5 years. Next subject is community medicine. In community medicine, we have two concepts. The first concept is criteria for public health problem. In order to publish or announce vitamin A deficiency as a public health problem, any one of the following criteria should be met. Night blindness more than 1%, Bitot spots more than 0.5%, corneal xerosis ulcer or keratomalacia more than 0.01%, corneal scarring more than 0.05%, and serum retinol levels less than 10 micrograms per deciliter more than 5% in the risk population. Here, the risk population taken under study is 6 months to 6 years of age. Next concept is disaster. During disastrous conditions like drought or famine, three important health problems happen. First is malnutrition, second is overcrowding, and third is health service collapse. In malnutrition, we can have both macronutrient and micronutrient deficiencies. In the macronutrient deficiencies, we are focusing on protein energy malnutrition, which leads to decrease in cell mediated immunity. In micronutrient deficiencies, we are focusing on vitamin A deficiency, which can lead to decrease in the quality of mucosal barriers. The second health problem we can have is overcrowding. Overcrowding generally increases the spread of contagious diseases, whereas in measles virus, the R naught is 12 to 18. R naught is the value which determines the spread of infection from a deceased patient to another patient. When R naught is more than 1, the disease spreads. When R naught is less than 1, the disease spreading stops. Here you can see the R naught value of measles virus is more than 1 and also is very high, 12 to 18. So measles virus is highly contagious in an overcrowded situation. Third health problem we have is health service collapse, which leads to poor cold chain. Cold chain is the technology by which vaccines are stored and transported. Poor cold chain results in decreased routine immunization. All these factors lead to measles spread during disastrous conditions of drought and famine. But as far as vitamin A is concerned, our takeaway for this topic is it leads to poor mucosal barriers, which increases the spread of measles. That's it for this topic. See you in the next one.